The webinar is being hosted by our Domestic and Family Violence Community of Practice. This is a group of our members who get together quarterly to explore practice issues and to identify issues for advocacy by DV New South Wales. The Community of Practice has scheduled a range of presentations on practice issues for this year, and its members decided that they would like to make these presentations open to the whole DV New South Wales membership. So I'd like to thank the Community of Practice members for identifying this practice issue and suggesting this presentation. I'd now like to introduce our speakers for today. So our panel of speakers have all spent time working for ACON, Australia's largest LGBTQ+ specialist organisation, and have extensive experience working with and for LGBTQ communities. Firstly, we have Liz Duck-Chong, who is Acting Manager of ACON's Trans Health Equity Division. She oversees the creation of TransHub, Here and Now, a resource for trans people who have experienced sexual assault, and other health promotion campaigns and projects. In her free time, she's a widely published freelance writer and filmmaker. Liz lives and works on Gadigal land. Eloise Layard is ACON's Program Coordinator for Sexual, Domestic and Family Violence. She works with community researchers and other domestic and family violence organisations to increase community knowledge and awareness of sexual, domestic and family violence, and to support inclusive practice and access to services. Eloise is also the co-convenor of the New South Wales LGBTIQ Domestic and Family Violence Interagency. And we also have with us, last but not least, Kai Noonan, who is the Director of Client Operations for the Women's and Girls Emergency Centre, or WAGEC. WAGEC is a feminist grassroots organisation and frontline service supporting women and children in crisis and working with the community to advocate for social change. Before working at WAGEC, Kai managed ACON's Sexual, Domestic and Family Violence project for LGBTQ+ people from 2015 to 2018, and then worked in the role of Associate Director of LGBTQ Health Programming and Development for ACON. So thank you so much to our speakers for agreeing to present today and educate us a little bit more about these issues. The format that we're going to have is that first Eloise and Liz will give us a presentation, and then afterwards we'll open to questions from everyone and discussion, and Kai will help us with expertise in answering those questions. So without further ado, I'm going to hand over to Liz to start the presentation.
Amazing. Thank you so much, Tamara. And thank you everyone for coming along today. It's really exciting to be able to co-present and to hopefully answer as many of your questions as we can. I'm just gonna share my screen. Is that good? Excellent. Amazing. Good thumbs up. Excellent. So Eloise and I are going to be talking just a little bit about LGBTQ plus affirming DFE care and kind of what that means for the LGBTQ plus community. I feel like, you know, I might cover some very basic things that everyone here understands, and that's okay. It's just good to make sure we're all on the same page. So LGBTQ plus is about all sorts of queer communities: lesbian, gay, bisexual, queer, pansexual, asexual, etc., and also trans and gender diverse people. And I'm going to be talking specifically a lot about trans and gender diverse people today, just in particular because questions around supporting trans people come up a lot in working in the kind of services that you're all in. So that's kind of where I'm going to be coming from. Before we dive directly into it, I also just want to acknowledge the lands that everybody here is gathered on today, where we're virtually meeting across all over this land, and that it always was and always will be Aboriginal land where we're meeting, and to pay my respects to elders past and present. So Thank you again. I'm going to get into first just a couple of definitions, just in case these are terms that you're not aware of, or maybe kind of know a bit what they are, but I've never seen them clearly defined. When we're talking about trans people or trans and gender diverse people, this is an inclusive umbrella term that basically describes people whose gender is different to what it was presumed for them at birth. And this includes trans men, trans women, and non-binary people, people of all identities. And it's just about that difference from what they were presumed to be, which is different to cisgender, which is the fourth one down there, which is just people whose gender is the same as what was presumed to be at birth. And these are really easy, fantastic terms for just talking about that distinction. I might also use the terms trans feminine and trans masculine today, which are umbrella terms for trans feminine is an umbrella term for trans women and some non-binary people. Trans masculine is a term for trans men and some non-binary people, just around grouping people into kind of presentation-based groups. And that can be helpful when we're talking about people presenting to services and appearance. And Eloise and I are also going to be talking a bit about cisgenderism today, which is kind of a way of talking about the discriminatory social or structural view that positions trans experience as not being real or as something that's pathologized or fake or medicalized, when in fact it's a really normal experience that a lot of people have. Cis people aren't normal, they're just slightly more common than trans people are, but the diversity that we have across cis and trans in gender is just kind of wonderful. If anyone has any questions about any of these things, we can definitely get into them a bit later. But I kind of want to dive into a bit of Agenda 102 first. I feel like everyone here is totally across Gender 101. So I want to kind of get a little bit deeper for getting into some of these topics before we dive into some questions later. And the first part of Gender 102 is when we're talking about anybody, but especially trans and gender diverse people, it's really important that we're thinking that genitals aren't equaling gender. When we think about the idea of like sex or sex characteristics, that often comes up in health systems or care systems, that those things aren't immutable and those things don't equal people's genders. And so this might look like chromosomes, this might look like secondary sex characteristics, this may look like genitals. None of these things can actively tell us what someone's gender is, only they can. And likewise, if we know what someone's gender is, if we know that someone's a woman or someone's a man, or if we know that someone's non-binary, that doesn't necessarily tell us anything about their body and how their body, how they use and live in and feel euphoric in their body, but also how they've been in their body dealing with experiences of trauma. So it's really, really important that we're listening to people talking about what these things are for them and what their personal experience is and not making those assumptions. I also want to talk a little bit about how trauma-informed care specifically works for trans people. I think that trauma-informed care is a really valuable, important way of talking to all people who are accessing services of all kind. But trans people have reported in a lot of research that going and seeing health services, going and accessing any kind of services, especially gendered services, can itself be incredibly traumatic. And so when we're thinking about providing trauma-informed care for trans people, for gender diverse people, we need to be thinking about how our systems aren't further traumatizing them by the nature of their previous bad health experiences or bad experiences of being gendered in certain ways or assumed in certain ways. And so when we're thinking about service creation, service use, service access, that has to be a really important part of that. And kind of the final really big part of the Gender 102 is that when we're talking about gender presentation, how someone appears, that's really one part of a person's gendered experience, whether they're trans or cis. Trans women, trans men, cis men, and non-binary people can all be masculine, feminine, or androgynous, or anywhere in the middle. And there's no way of telling that someone is any one of those identities by looking at them straight off the bat. We may have, we may make an assumption, but that assumption isn't always going to be correct, and that assumption can sometimes be harmful. So when we're thinking about how people are presenting and appearing and looking, that doesn't give us the whole story. And in fact, if we're just taking our experience on that, we can be perpetuating harm towards trans people and towards cis people because of that. And then I've just added this final point here about parts and practices, which is a model that we use in some of our sexual health clinics at ACON, which is more specific around, I guess, health provision, providing healthcare and support and things like that. But it's really thinking about, rather than thinking about identities or genders when we're talking about providing healthcare or providing support, thinking about the body parts that people have and the practices that they're doing with them. And this can come out in ways of, rather than asking what gender someone's partner is and therefore making an assumption about an experience that they've had, asking just about kind of what specific experiences happen and supporting them with that. And so not having to go through the process of accidentally misgendering or getting into a complex space around that with the people around this person. This is a bit of a whistle stop tour through some things. So I'm going to pass over to Eloise now. But thank you for, dealing with me just throwing some words at you.
And we do recognise, we are trying to cram a fair bit in because we do only have an hour together. We want to make sure there's heaps of time for questions, but towards the end of our discussion, Liz and I will also point you towards some further resources. So it is not that after today you're expected to memorise any of the words that we're talking about today or know it all by heart or feel like you're across 1000% of everything. Probably even Liz and I would say we're definitely not across everything either. We're a big diverse community, but we'll absolutely point you towards some additional resources as well. So I just wanted to start talking about the specific experiences of sexual, domestic and family violence that can occur for people in LGBTQ communities and what that can look like. And where I wanted to start was talking around what the drivers of sexual, domestic and family violence are in LGBTQ relationships. And this is something that I think it does come up a lot when I work with people in the sector, and I think that there can be maybe a sense of confusion about how we can understand LGBTQ people's experience of domestic and family violence when we are in a very gendered sector. And we're in a gendered sector because that's a really hard fought for win. It's something that we've probably many people here today have really worked and advocated for as feminist services, really recognising that domestic and family violence is gendered, and the majority of violence is perpetrated by cisgender heterosexual men against women. But when we look at the drivers of sexual, domestic and family violence in LGBTQ relationships, we can actually see that those drivers of violence, we're starting to get more research around this, that those drivers of violence are also really gendered. And so domestic and family violence in our communities is also caused by rigid expectations of gender and this privileging of heterosexual cisgender masculinity. So those negative and discriminatory social attitudes, norms and behaviours towards LGBTQ people actually influence violence against LGBTQ people, including violence used by LGBTQ people against their own partners. So people who are not heterosexual and or whose gender doesn't fit within a cisgender binary are policed and punished. And so we see that playing out even in intimate and family relationships. And some of the other sources of power that can play out as drivers of violence include race, age, income and employment. And so we're learning more and more and doing more work in the prevention and driver space. But what I think is so fantastic about this work that's coming out is it really helps us to see how, if we understand the drivers of violence and how they affect LGBTQ communities and we fight against those drivers of violence, we really see that the inclusion of LGBTQ people doesn't work against that really hard fought for gendering of domestic and family violence. It actually helps us expand it. And working against those drivers of, really rigid right ways of being a man or being a woman will actually also help increase safety for cisgender heterosexual women. So they are, I think, like inextricably linked and connected. So it's really great to kind of have some of this knowledge around that. And I'll share, once I've stopped talking, I'll share a resource called Pride in Prevention, which talks a little bit more breaking down some of those drivers rather than just sort of 2 points on a slide. And the other thing I wanted to mention is that it's really important to keep in mind when we're talking today that many LGBTQ people are in relationships with cisgender heterosexual men. For example, bi women, cis and trans, straight trans women. You may have lesbians who experience violence in former relationships with men or still have relationships with men as well. So we can't assume that even those sort of frameworks of men's violence against women aren't applicable to our communities, or that when I'm talking about domestic and family violence and LGBTQ relationships, that I'm talking exclusively about sort of same gender relationships. And thanks, Renata, for sharing that Pride and Prevention guide, beat me to it. So I just wanted to kind of provide this sort of first up to sort of get us thinking about what's going on and why sexual, domestic and family violence happens in LGBTQ relationships. I also wanted to touch briefly on what we know about prevalence. And again, I'll screen through this and I'll say, I guess, we don't have that same sort of level of research, and sort of those data collection is probably, I would say, poorer. So we don't have the same amount of evidence about domestic and family violence in our communities that we do for cisgender heterosexual women. But we do have some really important indicative data, and this comes, the next couple of slides all come from Private Lives 3, which is a recent national survey of LGBTQ people. Again, me or Renata, if Renata beats me to it, we'll share this one in the chat with you. But so of over 6,000 people that responded to this survey, when people were asked to report on specific forms of violence they'd experienced, 60.7% of the participants reported ever experiencing intimate partner violence, and 64.9% of participants reported ever experiencing family violence. And we can see some of those forms of violence on these slides here, and just how prevalent those rates are, including the physical, verbal, emotional abuse, and many other forms of violence. And one that I'll speak about soon is LGBTIQ related abuse. So I'll speak a little bit more about what that can look like soon. The other point I wanted to make, and it's really connected to thinking about the drivers of family and domestic violence, is that our communities are not homogenous, and that the experiences of violence actually vary in terms of sort of prevalence and experiences as well. So this is that same data from the same survey broken down by gender. And we can see that, you know, for non-binary people in particular, experiencing really high rates of intimate partner and family violence, intimate partner violence, physical, verbal, sexual abuse is all really high. So it's absolutely high for everyone in our communities, unfortunately, but I just like to show this data to show that it absolutely can vary within our communities, and that's important to know. Similarly, this is that same data broken down by sexuality. And so again, we can see that there are differences in prevalence. And this is just a really quick 101 sort of space to start thinking about how some of those experiences can be different and important to know. I think when we think about sexual assault, so that's inclusive of, we can see, so we've already seen some of that data for intimate relationships and sexual violence that happens in intimate relationships. But in that same survey, when participants were asked if anyone had ever coerced or forced them into sexual acts they didn't want to engage in, almost half of the survey respondents, so 48.6%, reported ever having been coerced or forced into sexual acts they didn't want to engage in. So we can see that this is really high for sexual, domestic and family violence. All of the prevalence rates that I've seen in Australia across multiple different surveys all point towards our communities experiencing rates of sexual, domestic and family violence at least the same rates as cisgender heterosexual women, and for some in our communities, higher rates. So that includes for bisexual women, cis and trans, and also for trans people as well, which I think you've seen in some of these slides that I've been going through. So again, this is just that sexual assault data broken up by gender. So we can see that there are extremely high rates of experiences of sexual assault for trans men and non-binary people, cis women as well in our communities, and cisgender men as well. Are really high. And so I guess it's important to think when we're looking at all of this data around what services are accessible to people in our communities if we know they are experiencing these really high rates of sexual violence, intimate partner violence and family violence as well. And then I've just got that same slide, same data again, broken up by sexuality, again, to kind of demonstrate that there are differences in our communities, but really high rates, unfortunately, across the board. And I won't read all those numbers out because we do have that Private Lives study in the chat. It's from page 70, which is, I'll remember the page section for this piece of work probably for the rest of my life because I refer back to it so much. So really encourage you to take a look there if you're interested in reading a little bit more of that data. It's also got some stuff around service access and things like that as well. So that's the prevalence, and I know I whizzed right through that. As Liz and I say, we just want to make sure we've got as much time for questions as possible. I suppose once we've thought about drivers and we've thought about prevalence, the other thing to think about is how intimate partner violence might be different in LGBTQ relationships compared to the relationships that cisgender heterosexual women are having. And I suppose we primarily say that all sexual, domestic and family violence is absolutely grounded in power and control, and that's no different for our communities. But that violence is happening within a slightly different context. And that's within a context of invisibility, where our relationships, including healthy relationships, are often really invisible. And also are existing within experiences of systematic discrimination that many people have experienced throughout their whole life course. And then the ongoing kind of effects of that discrimination and minority stress as well. We also know that there can be some different experiences of abuse itself, and we saw in that prevalence data that I was sharing in that sort of first slide with the graph, it was referred to as LGBTIQ related abuse. I also call it identity-based abuse at times as well, and here we sort of refer to it as using your gender and or sexuality against you. So that can look lots of different ways. So it can look like using someone's gender or sexuality against them, threatening to out people's sexuality, gender history, intersex status or HIV status, cutting them off from community events, pressuring people to conform to sex or gender norms. And we know we see this as well in men's violence against cisgender heterosexual women as well. You know, using offensive pronouns like it to refer to a partner's gender to purposely kind of ridicule and minimize someone's identity. It can also look like using people's knowledge of homophobic systems against them. So saying, you know, if you try to call the police, they're never going to believe you. They'll believe me because I'm bigger, you know, you're bigger than me, or they're just, you know, everyone knows it doesn't happen in our communities. You know, they'll just arrest you like they arrested you last time. So really using people's previous experience of homophobia, transphobia and biphobia against them to sort of stop people accessing services or disclosing their experiences. So there's just a few ways that violence can look. And when we're looking at reporting domestic and family violence and accessing services, again, I'm sort of screaming through some of our key points. I often deliver a full day training, so I've tried to squeeze as much of that as possible. We do have really low rates of reporting in our community. And just some of those reasons why are, you know, a fear of not being taken seriously, having a higher threshold to abuse because of really lifelong histories of experiencing discrimination. So actually never having had an experience of being respected or having a healthy relationship with someone else. Actually fearing gender or sexuality based discrimination from the service providers and a fear of being outed. And that's just a few of the reasons that we know of. There are certainly many others, like, you know, not being used to talking about relationships as well. So I'm going to pass back over to Liz to briefly go over a couple of case studies.
Amazing, thank you so much. So yes, we've presented these few little case studies for you. These are characters from a resource that our team developed last year called Here and Now. I'm just going to pop the link is in the chat there as well. Which is a kind of resource for trans people and also clinicians supporting people who've experienced sexual assault and receiving care after sexual assault. And so but we won't be talking about that resource today. We're just using the really wonderful animated figures from that to talk about some case studies of people who may and probably will show up to your service at some point. And we're presenting these case studies not because every service needs to see or support every single one of these people. That's definitely not the case. There's a value in spaces that are just for women and spaces that don't include men and things like that, but that all of these people have had an experience or have experienced domestic violence, and therefore we need to be thinking about how we support them even if our specific service doesn't. So I'll quickly run through just a little bit of information about each of these people. So the first two people here, Hannah and Claire, they're both women. Hannah is cisgender and Claire is transgender. Claire is also a sister girl, which is a term used by some Aboriginal or First Nations women, and brother boy is a term used by some Aboriginal and First Nations men. And Hannah was presumed female at birth, and She's cis because that's congruent with her identity now, and Claire was presumed to be male at birth, and that turned out to be wrong. Hannah is a lesbian, and Claire is heterosexual, so dates men, whether they be cis or trans, and they've both experienced domestic violence. So when they're presenting to a service, both of these women can definitely access women's DFV services, and sometimes that isn't the case. We definitely know that, you know, I've seen in the research that there are experiences of trans women who present to DFV services and struggle to gain access to them, or have a really difficult time out in them due to other people in those spaces. So it doesn't always mean that that access is a fantastic experience, which is something that we're really, really keen to help with. But both of these women can definitely access women's services. We then have Alex up next. Alex's pronouns are he, him, and he's a man. He's transgender and was presumed female at birth, which is yeah, not congruent with his current gender. Alex is also a gay man. He has sex with other men, trans and cis, and he's also experienced domestic violence. He is in a relationship with a man and experienced domestic violence in that relationship, and is now wondering where to go and what service to present to in order to access care. And we'll talk a little bit more about Alex in a little bit. And finally, we have Phoenix and Greer. And Phoenix and Greer are both non-binary. And non-binary is under the umbrella of trans. Some non-binary people posit their experience as being trans, some don't. But when we're talking about trans as a category of kind of care or service provision, we're including gender diverse people, non-binary people, genderqueer, gender fluid, all sorts of identities. Phoenix was presumed male at birth, and that's just not their vibe anymore. And Phoenix is pansexual, and Greer was presumed to be female at birth, and is bisexual. And, you know, we don't know a lot of details about Phoenix and Greer here, about, you know, how they like to affirm themselves, whether they are interested or not in medically affirming their gender or anything like that. That's not really information that we have available, but we do know that they've both experienced domestic violence and that they've presented to a service. And the reason that we're talking through these 5 case studies is these are 5 people who you'll probably see at some point. These are all experiences that we know, both from the research, but also just from being in community, that happen. People of all genders do experience domestic violence. And so we've got to be thinking about how we provide care to these people, if we provide care to these people in our services, and if not, who do we then connect them in with, direct them to, and make sure that there is care available for them. And yeah, it's, I think I mentioned a moment ago, but we're not at all saying that every service needs to accept every person here, just that when you refer people onto other places, thinking about what that might look like. So when we're talking about these figures in our case studies, the big question is, who does your service welcome? So some of these points might look like, who do you accept for intake? For example, do you only accept women? So trans and cis women? Do you accept women and some non-binary people, or all non-binary people, and kind of what that might look like and the legalities and difficulty of that? Or do you accept people of all genders? So women, men, and non-binary people. But not only who do you accept into the service, but how do you present and communicate that to community? Is that something that's available in marketing, on websites? Is that something that's purely word of mouth? Is that something that community will tell each other? Because oftentimes if a service is affirming for trans people will share that with each other. They'll be like, I had a really crap time. And someone else will say, well, go here. I know someone who went there and they didn't have a terrible time there. So how we kind of communicate who's welcome, essentially. And then if someone isn't welcome, or if your service is not for them, who do you refer onwards to? Like, do you have connections in with services that do provide care? So for example, in a service that only provides care to women, do you have connections with other services to gently and caringly connect other people in with, so that they're able to actually access the same level of care just from somebody else? And where does that look like? do you kind of have that connection there already? And then the final point there is, how does LGBTQ plus community, especially trans and gender diverse communities, but all queer people, how do they know that your service is inclusive? And I think that this is a question that's really valuable to break down by how would a cisgender LBQ plus person know, and how would a transgender person know? And that's really valuable because oftentimes if services say they're LGBTQ plus inclusive, or, you know, have a rainbow flag or something like that, trans people still probably won't engage with the service because there's no evidence there that they're not going to have a terrible time for being trans, even if they're affirmed for being LGBTQ plus. So it's not just enough to say, you know, our service is queer positive or LGBTQ plus positive, but we have to be thinking about specific aspects of those communities as well. So before we finish up the final slide for a little presentation, I'm going to invite Eloise to kind of join me in talking through this a little bit, which is essentially asking the question, what does make services inclusive? And the first answer is many, many things. We don't have one answer. We're not here to, you know, give you here's the 3 top tips to absolutely nail it. Like, it is a bigger question that is more complex than that. And that's why we're so chuffed to be part of this event and this panel in a second to ask this question, basically. But some of the basics include knowing and communicating who's able to access it without question, who may be able to access your service. So for example, if a service is accessible by non-binary people, even if that's not, you know, written on promotional material, and who can't access the service.
Good, thank you. How are you, Michelle?
It's about not conflating identities. So not conflating what someone was presumed to be at birth with their identity now, not conflating their genitals or their body or secondary sex characteristics with who they are. So for example, not assuming that everybody who has a vagina or who has breasts is a woman, or is comfortable with language around womanhood, and not assuming that everybody with a penis is a man or is comfortable with ideas around masculinity or malehood, and that those can be really harmful ways of talking about people who are already experiencing a lot of hurt. And really, honestly, things like training and knowledge building and keeping up to date with LGBTQ plus identities, language, community. I mean, 2 really great resources are TransHub and Say It Out Loud, which are 2 ACON resources. So, you know, a full disclosure, we're very proud of them. But they have really, really excellent information around supporting, for TransHub, for clinicians supporting trans people through all areas of care and support, and Say It Out Loud for sexual, domestic and family violence specific information. Really, really excellent. Definitely would recommend going and have a look at them after the session. And I guess committing to fighting cisgenderism in health services, thinking about gender as being this wonderful, expansive thing that we've I'm amazed and so just wonder, I can't even think of the words of like being able to speak to people who've been working in the sector and doing really, really beautiful work in talking about creating feminist services and fighting for such important things. And it's important that we continue to fight the way that cisgenderism exists as well, and the way that that normalizes and demonizes certain experiences, cis and trans. Yeah, Eloise, do you want to
I think
from there?
that's almost everything, and Liz captured it beautifully. Look, I do think it's around knowing what your policies and programs are in advance. So even if you can't work with someone, that you don't have to put them on hold while you find out whether you can work. Like, that's very othering. It really highlights, I think it could really make someone feel like, oh, I'm the trouble, my identity is the problem, where actually the problem is that our funding is really limited and that there aren't more services available. And so being able to have, I think sometimes those frank conversations can also be really helpful. I think, meaningfully engaging with the community, building up not just your referral pathways, or assuming that if you get an LGBTQ person in your service, they're just definitely going to be better off at ACON, but actually knowing, building up those connections with clinicians at ACON, so it might even just be asking a consult question, I guess talking about these issues. I'll also share in the chat a link to if today has been very whirlwind. I'm going to share a link to a training ACON's currently offering for free around sexual violence and LGBTQ people, which also covers a lot of the 101 stuff around language and asking about pronouns and inclusivity a bit more in depth, but you can still do it in your own time, which I think is really helpful. The other thing that I would say is, if you don't currently work with a lot of LGBTQ people or have a lot of LGBTQ loved ones in your life, even just engaging in media, telling our stories of our community, watching the videos on TransHub, just getting yourself used to different identities and voices and faces. And I think that can be a great way to kind of get more comfortable with things like pronouns and language as well. Yeah, that's my very quick little spiel. And thanks so much for having us here.
Definitely finish the slideshow. I've just pop our emails here. We'll also pop them in the chat if there are any follow-up questions or if you want resources or things like that after the session today. But that is us, our little presentation done. Thank you so much.
Thank you so much, Eloise and Liz. That was such an excellent presentation and so informative, and covered such a lot of ground, from drivers and prevalence and terminology to access and inclusion issues. We're now going to open the discussion to anyone who wants to ask a question. You can ask a question by going to reactions on the menu bar, which is at the bottom of my screen. So I hope so for everyone. And if you raise your hand, I'll know that you have a question, or you can also pop questions into the chat. We've already had one question in the chat that I noticed from Sid, so I'm just going to find it. Yes, Sid says, just wondering if you consider the driver of religion as a factor for DV in LGBTQ plus people, and how you consider this when supporting clients.
I guess I can jump to start, but
yeah, thanks.
Anything on. And look, I'm not an expert in the prevention and driver space. There are definitely people that are doing more of that work. To me, I would say it's probably more around those rigid gendered norms and the right way to be, but sometimes the way, ideas I should say, around the right way to be. And I think sometimes that can be expressed through religion, like people, yeah, a lot of those cultural and gender norms and things like that can be couched within terms of religion. And so absolutely someone that has grown up in, maybe a really religious conservative family, that can absolutely impact on their experience of violence. Whether I would say it's the religion itself, I think it's more around, yeah, some of those cultural attitudes is probably what I would say.
I might just pop in there as well, which is, I think
sure.
It's also just really important to talk about. It's not ever a case of religion as being something that's anti-LGBTQ plus or things like that. Like, I think that there's a lot of conversation around the fact that a lot of LGBTQ plus people have difficulty with religion, but there's also a lot of LGBTQ plus people who are religious and find a lot of comfort and support in religion and their religious communities. So it's just really important to not assume that because someone is part of an LGBTQ plus community that their experience of religion is necessarily negative or a detracting factor in any way, and can in fact be a place of really valuable support and care. But again, it just really comes down to the individual.
Thanks so much for those answers. We have a question from Yvette in the chat. She's asking whether guidance from funding bodies for WDV, CAS, SHLV and other programs is clear enough when it comes to supporting the LGBTQI plus community. Does anyone feel like they can speak to that?
I'm happy to jump in if you would like.
Yes, go ahead.
I've been pretty quiet for now, so I feel
yes,
like
you have, but we do want to mine your expertise.
No, that's fine. That's fine. I just saw Eloise's face and I was like, this is such a tricky area.
Yeah.
When I started working in the advocacy space specifically for LGBTQ communities and domestic and family violence, we were just starting to see the inclusion and the emergence and the use of our communities throughout some of the state and national legislation. And it was really led by New South Wales. And now kind of Victoria really leads in this space. I would say that the domestic violence sector is doing a lot better than, say, other sectors. Like, I'm now kind of straddling the domestic violence sector and the homelessness sector, and I'd say what's happening in the domestic violence sector is actually pretty impressive with the inclusion of our communities. For example, probably half of us here are heading to a workshop straight after this, the roundtable for the new national plan. So it is getting a lot better. We are included. Unfortunately, where we still have a sticking point is the wording around a lot of the funding. And it's actually the wording that stops us from being able to work with people who fit outside of that heterosexual binary of male perpetrator, female victim. So I remember when I was working for ACON, we had a really good funding proposal, and literally the funders were like, we don't know where to put it because of that wording. And I think that's the problem. We are getting better at including our communities, but by and large, the funding, the legislation is still there to protect women. That is the terminology that's used, and that's why it's a little bit harder for our communities as well. I know with ACON, some of the work we've been doing is designed specifically to be for female victims, but within that, we're able to do some work outside of that for the rest of our community as well. So I hope that answers your question. I think we are doing well and we are getting a lot better, but there is still a lot of work to go, and it's that wording alone that really stops us from being able to do some of the work we'd like to do, particularly with male victims and non-binary people as well.
Thanks, Kai. That's really interesting. It's good to know that we're ahead of other sectors, and also to know that the main block is the wording, because that's something we can then pay more attention to in our advocacy and in terms of being more inclusive. You sort of segued into this area already, but we have a follow-up question that Renata's put in the chat for you, Kai, which is, how does a women's service like WAGEC ensure they are inclusive, and what do you do if you get a non-binary person referred to you?
Yeah, so for those people who don't know me or maybe missed the beginning bio, so I used to work for ACON in the violence and advocacy space. I went into that work because I was doing frontline domestic violence work years and years ago, and what I was seeing was that LGBTQ people were not presenting at domestic violence services. When I worked in the drug and alcohol sector, there was huge numbers of our community who also presented with trauma and domestic violence, but they were not showing up in the domestic violence sector. So that's what interested me in working for ACON. Now I've gone back to work in a frontline service. And despite, I'm going to be really honest here, because I think honesty and these really difficult, challenging conversations are what we need to have, because we know the stats. And Eloise and Liz, I just want to say you did such an excellent job presenting just then. It was really interesting and a really concise and clear way of explaining in such a short time how complex our communities are. But I do want to open up to have a really frank discussion. I do think that WAGEC is a particularly inclusive service. I met WAGEC 5 years ago, and they reached out to me working at ACON, asking us for support to make their service inclusive. In our last client survey at the end of last year, 42% of our staff identified as being part of the LGBTQ community. So almost by default, we're inclusive. And we've started a lot of that work, but we still have a long way to go. Roughly 15-16% of our clients are LGBTQ, which is great because it says that they're coming through the door. But I don't know what work we're actually doing with our community, and I don't know how great that work is because we're not collecting that data. And what I'm trying to say is that some of the work is being done, but a lot of it isn't. The part that I want to bring up that is a little bit of a challenging conversation, and I'm going to bring myself to this conversation. I identify as non-binary. I use they, them pronouns, but I work in a women's service. You won't see my pronouns on my bio. You won't see it on the email that went out to everybody promoting this. I don't use it at work. I can see a couple of my staff are here. They may have never heard this. They might be hearing this for the first time, because I work in a women's service and I don't identify as a woman. And I want to bring that because I think these are the conversations that we need to have. When I went for the job at WAGEC, I made it really clear. I had those discussions with my manager and the people recruiting, and we had to think about what does that actually mean. We put it down to safety. So we said the reason why it's a women's service is because it tends to be safer for the women who access the service. So we looked at, I guess, myself, how I'll be read, how I can present, and we decided, is that safe? Will the clients feel unsafe by me being there? And we decided, no, I don't present a safety issue. In saying that, what it means is that I don't use my pronouns, that I get called ladies, that I just don't bring my full authentic self. And it means that I'm robbing my staff of the opportunity to be able to use correct pronouns, to be educated and aware of what it means to be non-binary. But I think what I loved about Eloise's and Liz's presentation then was that they said, look, you don't have to bring in people of all genders. We understand why there are women's spaces. However, you need to be having those conversations before you get a non-binary or a gender diverse or a transgender, for that matter, or a male cisgender client or staff member. You need to have those conversations first, and you need to decide what it means for your service and what you're actually going to do before they show up to your door. And I think I just really invite you all. I think this sector really, really wants to be inclusive. Of course, we take low-paying jobs in really hard-working spaces so that we can do the right thing by people who need help. But we need to be really honest about what does that look like and what are the parameters within which we're working, because we are in a gendered sector. We are guided by funding. We do have names for our organisations like Women and Girls Emergency Centre. So how can we be inclusive? Can we be authentically inclusive? And if we can't bring in particular people, then what do we do then? Because we do have a responsibility to make sure that they get a service of some kind, even if it's not with us. So I just wanted to bring my own experience to the table, because I think it might help to shed a light on really how it's working on the ground and what that actually means. And I'm happy to take questions about that, but yeah.
Yeah, thanks so much, Kai. Really appreciate your willingness to be so open about your personal experience. And
I just jump in if that's okay. And
yeah,
say,
sure.
And say thank you as well so much, Kai, for sharing that and for the expertise and the insight that you're bringing. I think it's really valuable to reflect on the fact that that is an experience that a lot of trans people have in so many services. Like, I think that I'm not sure exactly how much the research reflects this in this sector, but I know in the HIV sector and other sexual health areas that trans people will present themselves to services in a way that is kind of delegitimizing or misgendering in order to access services. Like, trans people will go out of their way to receive care for a lot of things, even if it means having a really unaffirming experience. And I think that is potentially an experience that happens in this sector as well, without us realizing or without us knowing. And so it's often that there will be trans people attending services without you even really knowing, because they've decided that they're just actually not going to share their pronouns, or they're not going to correct you, or it's not worth the trouble, or they're worried that it might become a big issue. And so I think when we're thinking about ways of creating affirming spaces, we're talking about people who are already coming in and accessing services and who are already clients and are already receiving care, but maybe aren't being affirmed while doing so. And so it's a conversation about not a client base that is entirely external, or staff members that are entirely external, but it's about people that may already be seeing and can do more to care for.
And can I just add one little point to that, Liz, as well?
Sure.
I'm lucky. I've come into this position as a director. So I come in as a person with some power and some influence. I don't come in managing trauma or having to manage my mental health on a daily basis. So it is very different for me than it is for a client in our service. And as somebody who identifies as non-binary, every time I access a service, I am hypervigilant and I have to decide, is it actually worth it? And we know how hard it is for victim survivors or people experiencing any kind of abuse to actually access help, especially if they then have to decide, do I want to lie about who I am? Do I want to put up with having to be called ladies? Do I want to have to walk in feeling uncomfortable? Do I have to sit in a women's space and wonder if everybody's looking at me? Like, I just want to highlight that I can bring my experience, and I hope it was helpful, but I do come from a really privileged position. And when we're thinking about staff and we're thinking about clients, we need to think about how to keep both of them safe, because it'll probably be very different experiences for our clients and our staff as well. And when I say safe, I mean all kinds of safety, not just physical safety.
Yeah, They're all really important points, and I think it helps those of us not coming from a trans or non-binary experience to understand a little bit about the issues trans and non-binary people experience in accessing services. We do have quite a few comments and questions coming in, and I'm just conscious we've only got 5 minutes. We do have to end right on time because people have a meeting for the National Plan Advisory Group just after this. So I'll get to as much as I can, but this question seems to be related to what we were talking about, in that we're talking about access and eligibility, and the fact that it might not always be, your service might not always be accessible to non-binary people, but how do you communicate that, and how do you refer them somewhere where they can get a decent service? So this question relates to that. This is from Jean. She says, as a women's service with eligibility criteria that say the person must be over 18 and identify as a woman, how might we better communicate our incapacity to work with non-binary people? Anyone want to jump in and answer that?
I would say using words like, when you're talking about women, including women brackets cis and trans, so you're being really actively inclusive and being clear that you're including trans women in that. And by not saying non-binary, people will understand you're saying you are a women's service,
Okay.
and you work with women, cis and trans. That'll be my own personal perspective. But of course, some people will may use, for example, in Liz's case study, she and they pronouns. So they might identify as both within a non-binary umbrella and being really connected to an experience of womanhood. So it may be that you do still work with some people that might also describe their identity as being connected to non-binary identity, but very much are still comfortable in women's spaces and identify also with womanhood. So it does get complicated. I'm sure Liz probably has better thoughts than me around language, but I think that's one thing I wanted to get across for women's services, to be still really active about saying cis and trans women, so that trans women are really made actively aware that that is a safe space for them, if it is.
Absolutely.
Sure.
And I just second that. I think that, like, as a trans woman, seeing women cis and trans makes me feel so much better than seeing women and wondering, like, what does that mean for that person? So yeah, I would just second that. But also, yeah, it's a really complex one of trying to communicate that incapacity. And I think that being really clear and defined about women is probably the best way to do that. And then probably having some kind of internal system or policy or discussion around the fact that, you know, non-binary people who are feminine or who aren't medically affirming their gender and presumed female at birth may present to the service, and kind of, I guess, how to engage with that if you do, or if it's kind of a thing where if people do present that they might get misgendered in the service, and kind of, I guess, having a process of trying to minimize that, or trying to, I'm not exactly sure. I don't really have a good answer about that, but I think, yeah, going back to accepting that people may still try and access the service who aren't women, but who may pass as women or appear as women because they need the care.
Yeah. Okay, I'm really conscious, unfortunately, that we have to wrap up, and this has been such an interesting discussion, and there's many more questions, but Renata has put in the chat, Renata's our policy and research manager, I should add, that we're asking services to fill in a short survey about COVID for our advocacy, which should only take around 3 minutes. If you're able to do that, we'd really appreciate it, because we're trying to advocate for your needs during this lockdown period. I'm really sorry, Nathan, you've had your hand up for so long and I haven't come to you. Delia, you have your hand up. Would you like to add anything?
Oh, I was just adding a thumbs up on the COVID survey, and I guess we might try and collate the last few questions, including Nathan, and try and get some answers. So sorry, everyone. And I will have a lamp. I've just moved house, so I'm so sorry I'm dark and hiding. But what an incredible session. I'm blown away by the openness, the honesty, and the safe space that's been created, and could not be more grateful. Thank you so much.
And if anyone has more questions that they'd like us to answer, feel free to email the DV New South Wales team, any of us, and we'll collate those questions and try to get you answers to those questions. And thanks very much for attending, everyone. We really appreciate your attendance and interest and look forward to seeing you at the next seminar.